Good afternoon, dear colleagues. Our today lecture is devoted on diseases of kidney. First, we start from normal histology of kidney. We can remind that the structural functional unit of the kidney is nephron. Nephron is consisting of three main parts. The first initial part is glomerulus. Glomerulus is a combination of capillary loops and the lumen of Bowman capsule with parietal layer, which is limited with parietal layer. Function of glomerulus is filtration of the blood and formation of primary urine. After that, after filtration, primary urine first accumulated in the Bowman capsule, in the cavity of Bowman capsule, and after that passing to the proximal convoluted tubule. Proximal convoluted tubules, this is next part of nephron, and the proximal convoluted tubules after loop of Henle will go to the distal convoluted tubule. Convoluted tubules function is a combination of two processes, secretion and reabsorption. Secretion and reabsorption, both of them are active transport mechanisms which is requiring the energy which our cells can obtain from ATP, adenosine triphosphate. Secretion is active transport of some substances from the blood additionally to the urine. Reabsorption is oppositional process when some substances are removed from urine and returned back to the blood. So, combination of these three processes, filtration, secretion and reabsorption, are necessary to form the urine and to for removement of waste products, nitrogen waste products. Of course, it's urea first of all, and some other substances. Volume of pure primary urine which is formed due to processes of filtration is very large. It can be tens and hundreds of liters per day. Secondary urine, which is formed due to secretion and reabsorption, is less, and in healthy patient and healthy person, amount of secondary urine is equal to the volume of consumed fluid during the day, usually not more than 2 liters per day. From distal convoluted tubules, urine is collected by collected ducts, and these collected ducts are passing through the medulla substance of kidney, forming the pyramids which can be seen macroscopically, and collecting ducts are opened on the apex of papillae in the pelvic calyceal system of kidney. Pelvic calyceal system consists from few calyces which fuse one with another and form large renal pelvis. From renal pelvis, secondary urine passes to the ureter, then to the urinary bladder, and after that through the urethra to environment. All diseases of kidney can be determined as 5 groups. 5 groups of diseases are glomerulopathies, tubulopathies, interstitial diseases, tumors, and congenital anomalies. Glomerulopathy is disease which affects glomerulus. Tubulopathy is disease which leads to the damage of convoluted tubules of kidney. Interstitial diseases, these are diseases which affect stroma between convoluted tubules and around glomerulus, or inside it between capillary loops. Interstitial diseases very rarely occur like separate diseases, but usually is combined with glomerulopathies or tubulopathies. Sometimes it can be true interstitial disease without involvement of tubules and glomerulus. All renal symptoms which can be found in any diseases of kidney can be divided into groups. These groups are renal symptoms and extrarenal symptoms. What are they? For renal symptoms, main symptoms are pyuria, hematuria, cylindruria, leukocyturia, bacteriuria, and oliguria. For extrarenal, edema, hypoproteinemia and dysproteinemia, hypertension, hyperazotemia, and anemia. Let's discuss in details. Renal symptoms can be found in common analysis of the urine, which is can be performed in any clinics or hospital. Extrarenal symptoms can be found with physical examination or with biochemical examination of blood or common analysis of blood like anemia. Pyuria and leukocyturia. Pyuria, its presence of pus in urine. Leukocyturia, its presence of leukocytes in urine. Leukocyturia, its mild form of pyuria, because pyuria means the amount of leukocytes in urine is very large, and presence of such amount of leukocytes in urine can be found in severe purulent inflammation. So, leukocyturia, mild variant, pyuria, severe variant of the same process, presence of leukocytes in the urine. Usually, in healthy patient, amount of leukocytes is not more than few in field of the view in microscope. Hematuria. Hematuria is blood in urine. Of course, mostly these are erythrocytes. In healthy patient, amount of erythrocytes in one field of view in microscope also not more than few erythrocytes. Cylindruria. It is presence of different casts in the urine, cylinders. These cylinders more often are hyaline cylinders, but sometimes it also can be result of cystine, xanthine cylinders and some other. Bacteriuria, presence of bacteria in the urine. Usually bacteria are absent and urine is sterile in healthy patients. Oliguria and also anuria. These are symptoms which can be found in patients who suffer with some problems of urine outflow or maybe due to renal failure, acute renal failure. Oliguria is decreasing of the amount of daily urine less than 500 milliliters. Anuria, its total absence of urine output during day. Oliguria and anuria, as I told, these are severe symptoms which can be detected in critical conditions like acute renal failure. Also to renal symptoms, we can add some additional variants. These variants are proteinuria. Proteinuria, as we can understand from the name, it's presence of some amount of protein in the urine. Usually, protein in urine is absent. Next renal symptom is glucosuria. Glucosuria is presence of glucose molecules in urine, which in healthy patients are also absent. Glucosuria, I hope you understand, this was one of the signs of diabetes mellitus, in which amount of glucose is increased both in blood, and when this amount of increased glucose is very high, it also can be detected in urine. Let's discuss extrarenal symptoms. Extrarenal symptoms can be found, as I told, with physical examination of some additional methods of investigation, laboratory studies, but laboratory studies of blood. Renal symptoms can be found with laboratory studies of urine. So, what are extrarenal symptoms? First of all, edema. Edema due to disturbances in water saline metabolism and due to accumulation of water in the organism. Hypoproteinemia and dysproteinemia can be manifested as a result of proteinuria. In case of severe loss of proteins with blood, the amount of proteins in blood, proteins are lost with urine, but amount of proteins in blood will become decreased. That's why hypoproteinemia. And because mostly the proteins which are lost by organisms, these are albumins, we will see this imbalance between albumins and globulins, so dysproteinemia, disturbed composition of the blood according protein molecules. Hypertension. Hypertension is clinical manifestation and it means increased blood pressure. Because kidneys are organs which very actively participate in saline-water balance, and because kidneys are organs which are responsible for production of renin, which is initial component of renin-angiotensin-aldosterone system, that's why any damage to the kidneys can lead to hypertension. Hyperazotemia. It's increasing amount of nitrogen-based products in the blood and can be found also in case of critical conditions such as renal failure. Anemia. Decreased amount of hemoglobin and erythrocytes in the unit of blood volume in 1 milliliter. Damage to the kidney can lead to anemia because blood can exit with urine in case of hematuria symptom, or also composition of blood can be changed in case of damage to the erythropoietin synthesizing system. It's some group of active cells which are responsible for production of erythropoietin. Erythropoietin stimulates erythropoiesis in bone marrow and is produced in kidney. That's why damage to the kidney can lead to anemia. First disease which we will discuss with you is glomerulonephritis. Glomerulonephritis is the disease from the group of glomerulopathies. Glomerulonephritis, infectious and allergic disease or disease of unknown nature, which is based on bilateral diffuse or focal non-purulent inflammation of the renal glomeruli with the presence of renal and extrarenal manifestations. Few important notes about glomerulonephritis. So, first of all, nature of it can be infectious, allergic, and unknown, idiopathic. Second important moment, bilateral damage to kidney. Both kidneys are affected in glomerulonephritis. It's one of the important difference from pyelonephritis. And third important note, non-purulent inflammation of glomeruli. So, glomeruli are damaged, not convoluted tubules. They can be damaged secondary to glomeruli. First initial injury will be found in glomeruli, and the manner of this injury is non-purulent inflammation. What is the mechanism of glomerulonephritis development? Two main mechanisms are valuable: autoimmune mechanism and immunocomplex mechanism. In autoimmune mechanism, first initial stage, it is damage to the basal membrane. As a result, autoantibodies are synthesized in the immune system and they attack basal membrane. Adhesion of autoantibodies is seen to the components of basal membrane. Due to adhesion of antibodies, complement system will be activated, which lead to severe damage of basal membrane, increased amount of antigens of basal membrane in the blood. That's why additional activation of synthesis of autoantibodies and other cytokines and inflammation, and result damage of glomerulus. Immunocomplex mechanism. In first stage, there will be formation of circulating immune complexes. These immune complexes will penetrate into glomerular mesenterium. They have tropism to glomerular mesenterium. In glomerular mesenterium, insoluble immune deposits will be formed. Due to accumulation of these immune deposits, complement system become activated, which lead to the damage to the basal membrane, liberation of chemoattractants, and that's why chemotaxis of neutrophils and monocytes to the glomerular mesangial space, synthesis of cytokines and growth factors, and result of it, progression of inflammation and damage to glomeruli. If you remember well immunopathology, you can understand that autoimmune mechanism is mostly hypersensitivity reaction type 2, and this mechanism is mostly hypersensitivity reaction type 3. Main clinical syndromes of glomerulonephritis, these are nephrotic syndrome, nephritic syndrome, and slowly progressing uremia. Let's start from the last one, slowly progressive uremia. It is associated with higher lenosis of glomeruli on the background of chronic glomerulonephritis. Microscopically, we will see progressing accumulation of homogeneous eosinophilic masses within capillary loops and between capillaries, leading to narrowing and as a result obliteration of the lumen of the capillaries and then of the Bowman capsule. Slowly progressive uremia can be detected only with biochemical analysis of the blood. In case of this variant of clinical manifestations of glomerulonephritis, other symptoms are usually absent. Nephrotic and nephritic syndrome, let's discuss in details. Nephritic syndrome. The first initial link of nephritic syndrome is damage to glomerulus. Due to damage of glomerulus, filtration process is disturbed severely. Result of it, oliguria, decreased amount of urine output. Because of damage of glomerulus and due to disturbances in filtration process, erythrocytes begin to pass to the urine. That's why Coca-Cola colored urine and its manifestation of renal symptom, which is named hematuria, presence of RBC in the blood. That's why Coca-Cola color, discoloration of the urine. After that, next component of nephritic syndrome, it's mild proteinuria. Mild because proteins are lost from the blood, mostly with erythrocytes, because proteins are components of erythrocytes. Erythrocytes consist from some amount of proteins, and also some additional protein molecules like albumins due to damage to glomerulus and disturbances in filtration process. Amount of proteinuria not very high, less than 2 grams per day. Next sign, it's arterial hypertension, and it's also result of damage to the glomerulus because the cells which are responsible for renin-angiotensin system activation are mostly located near the glomerulus, in juxtaglomerular apparatus, and also due to disturbances of urine output due to oliguria, accumulation of additional amount of water in the organism, and that's why arterial hypertension. Nephrotic syndrome. Nephrotic syndrome starts from damage to glomerulus, which result to the massive proteinuria. More than 3-4 grams per day of proteins is lost with urine. Because of it, decreasing amount of proteins in the blood and hypoalbuminemia and hypoproteinemia. Mostly proteins which are lost with urine with massive proteinuria, these are albumins. That's why amount of albumins will be decreased faster than amount of other proteins. Hyperlipidemia is compensatory reaction, non-specific response of the liver on reduced plasma oncotic pressure and reduced catabolism of lipoproteins. Because albumins are important components of lipoprotein molecules, and in case of decreased amount of albumins, additional amount of lipids will be liberated to the blood, and also synthesis of lipids will be increased in the liver. About oncotic pressure. Oncotic pressure, I must to remind you that it's pressure which is formed due to action of protein molecules in the bloodstream. So, molecules of protein accumulate the water molecules and causing oncotic pressure. In case of decreasing amount of albumins in hypoalbuminemia, oncotic pressure also becomes decreased. Because of it, a liquid part of the blood will pass through the vascular wall to the peripheral tissues, causing massive peripheral edema. One more time, let's repeat components of nephritic and nephrotic syndrome. Nephritic syndrome consists from damage to glomerulus, which leads to oliguria, hematuria, arterial hypertension, and mild proteinuria less than 2 grams per day. Nephrotic syndrome consists from damage to glomerulus, which leads to massive proteinuria. As a result, loss of proteins and hypoproteinemia, hypoalbuminemia. Non-specific reaction of the liver to this hyperlipidemia, increased amount of lipids in the blood. And result of loss of protein and result of decreasing oncotic pressure, it is peripheral edema. About edema, we will have additional slide. First of all, anasarca is generalized systemic edema of the soft tissues. In this disturbance, edematous fluid will accumulate in soft tissues of the patient and also in serous cavities. Like here we can see example of ascites, accumulation of serous non-inflammatory fluid in the abdominal cavity. In the left slide you can see typical appearance of kidney renal edema. Renal edema and cardiac edema have different signs. Cardiac edema, severity of it is increasing during day. It happens due to physical activity of majority of peoples during day. Humans are moving, they make some physical activity, they participate in some mental activity, and so on and so on. Due to this, increased amount of blood is passing through the heart, because all these activities are necessary with oxygen and nutrients to be performed. Edema in case of cardiac diseases are mostly present in lower extremities, in the lowest part of the body, because usually humans are in vertical position. That's why during day increasing amount of fluid will be accumulated in soft tissues of lower limbs. Contrary to this, renal edema usually developing during night when patient is inactive. It happens because, first of all, amount of urine output during night is decreased. Daily amount of urine is much higher than night amount of urine output. Secondary, the gravity is one of the helping factor to the passing of urine through the ureters from kidneys. When patient is in vertical position, urine is much faster passes to the urinary bladder and then to urethra. In night, when the patients are sleeping and are in horizontal position, gravity cannot help urine to pass to urinary bladder. That's why urine is mostly accumulated in pelvic calyceal system, and that's why urine output during night is decreased, and water part, liquid part of urine and liquid part of blood will be preserved in the soft tissues of the patient. Especially this edema can be found in upper part of the body, like here in palpebra and in soft tissues of the face and neck. Principal classification of glomerulonephritis include few principles. First, due to origin, due to etiological factors, glomerulonephritis can be divided into primary, secondary, and hereditary. According clinical course, acute, subacute, and chronic. According to vascular component, it can be divided into intracapillary and extracapillary. According type of inflammation, exudative, proliferative, and mixed. According to the extent, diffuse and focal. Its detailed classification according etiological factors. Primary glomerulonephritis, which develops without any previous disease of kidney, can be subdivided into acute diffuse proliferative glomerulonephritis, rapidly progressive glomerulonephritis or subacute variant, membranous glomerulonephritis, lipoid nephrosis, focal segmental glomerulosclerosis, membranous proliferative glomerulonephritis, and chronic glomerulonephritis. These are all variants of chronic variant of clinical course of glomerulonephritis. Secondary glomerulonephritis usually develops on background of some other disease, mostly systemic diseases of connective tissue. Secondary glomerulonephritis can develop in systemic lupus erythematosus, in systemic vasculitis such as Goodpasture's syndrome, periarteritis nodosa, Wegener's granulomatosis, and some others. Also, it can be found in endocrine pathology diabetes mellitus or in amyloidosis. Hereditary glomerulonephritis includes two most important diseases, Alport syndrome and Fabry disease, and hereditary variant is developing due to congenital mutation of some genes in genetic apparatus of the cell. Morphological classification of glomerulonephritis includes three main types. First type is diffuse intracapillary glomerulonephritis, which is named acute glomerulonephritis or acute post-streptococcal glomerulonephritis. Second one is extracapillary glomerulonephritis with crescents, rapidly progressive glomerulonephritis or subacute. And chronic glomerulonephritis, which includes few morphological variants. First of all, it's glomerulonephritis with minimal changes or lipoid nephrosis, minimal change disease. After that, membranous nephropathy, mesangial-proliferative glomerulonephritis, mesangial-capillary glomerulonephritis, focal segmental glomerulosclerosis, and fibroblastic glomerulonephritis, which is actually possible outcome for all above-mentioned forms of glomerulonephritis. According extent, glomerulonephritis can be divided in intracapillary and extracapillary. In intracapillary variant, the damage is located only within the capillary loops, inside the capillary lumens or in mesangial space between capillary lumens. In case of extracapillary glomerulonephritis, the damage of glomerulus starts from the lumen of Bowman capsule. Inflammatory cells and other cells will be accumulated in the Bowman capsule, leading to compression and damage to capillary loops of glomerulus, and after that possible outcome as glomerulosclerosis. We are starting from acute post-streptococcal glomerulonephritis. Usually this type is often can be found in children, but also not rare disease in adults under the 40 years old. Mostly men are affected. The main cause of glomerulonephritis is beta-hemolytic streptococcus group A, so often acute glomerulonephritis is called post-streptococcal glomerulonephritis. So, disease is characterized by the association with streptococcal infections like tonsillitis, pharyngitis, scarlet fever, pyoderma, and other disease. Any disease which can be caused by beta-hemolytic streptococcus group A. But damage to glomeruli happen not due to primary damage from infectious, not due to primary damage of bacteria to glomerulus, but due to formation of immune complexes or formation of autoantibodies to the components of glomerulus, especially to the basal membrane. What are the clinical manifestations of acute glomerulonephritis? Acute onset, first of all, started from fever, nausea, and malaise. Rapid development of nephritic syndrome. I would like to remind you, it includes oliguria, hematuria, mild hypertension, and mild proteinuria. As a result of it, slight edematous syndrome, mostly in the face. Usual duration of acute glomerulonephritis from 1.5 to 12 months. Mostly it passes within 3 months. Prognosis mostly favorable. Recovery is seen in almost 90% of patients. It's very important to know that acute post-streptococcal glomerulonephritis cannot be transferred to chronic one. Chronic glomerulonephritis and acute glomerulonephritis, these are two separate diseases, and acute glomerulonephritis cannot pass like chronic one. If from beginning glomerulonephritis is acute, it passes like acute. If from beginning glomerulonephritis is chronic, it passes like chronic. Acute cannot transfer to the chronic. What are clinical manifestations? As I told, it can pass with nephritic syndrome, with nephrotic syndrome, which is the rarest variant, or with isolated urinary syndrome. The symptoms which are seen in nephritic syndrome: edema, shortness of breath, headache, nausea, vomiting, weakness, arterial hypertension, which is usually mild, hematuria, decreased diuresis, decreased glomerular filtration, in severe cases azotemia. With isolated urinary syndrome, which passes without any clinical manifestation except changes in analysis of the urine. It's painless hematuria, oliguria, proteinuria, leukocyturia, and cylindruria. And the rarest variant, nephrotic syndrome, is accompanied by hyperlipidemia, severe proteinuria, hypoproteinemia, and pronounced edema. Morphological appearance of kidney in acute glomerulonephritis, it's large mottled kidney. Kidneys are increased in sizes. I remind you that it's bilateral disease, so both kidneys are affected in the same time. Consistence of them is flabby. External surface is smooth and have a lot of red dots. Cortex is usually white and full-blooded. On the cut surface, we also usually can find a lot of red dots due to petechial hemorrhages. Microscopically, we will see signs of glomerular hypercellularity. It happens due to proliferation of mesangial cells and also vascular endothelial infiltration by polymorphonuclear leukocytes, means neutrophils. Also, some epithelial cells of the outer layer of the Bowman capsule can begin to proliferate. These epithelial cells are located on the external surface of capillaries in the border with lumen of Bowman capsule. The result of it, narrowing of capillary lumens due to edema and due to swelling of endothelial cells. Immune complexes can be detected with electron microscopy like characteristic clumps in the basal membrane of capillary loops. Here it is typical morphological picture of acute post-streptococcal glomerulonephritis. Glomerulus is damaged. Hypercellularity is seen. Hypercellularity due to proliferation of mesangial cells. Due to edema, we can see narrowing of the lumen of capillary. And infiltration with polymorphonuclear cells is seen. In details, we can find a lot of polymorphonuclear cells indicated by arrows. Hypercellularity, narrowing of the capillary lumen. Possible complications of acute glomerulonephritis are all usually associated with clinical manifestations of arterial hypertension, which are pulmonary edema, eclampsia, that means convulsions in the background of the cerebral edema because of arterial hypertension, visual impairment also due to hypertension, due to edema of retina and retinal detachment. Possible complication from kidney is acute renal failure, but it can be seen only in rare cases. Here is the slide in which we can detect components of immune deposits in the basal membrane and also with immunofluorescent method presence of immunoglobulins class G, class M and C3 component of complement system also can be found with immunofluorescent method. Next type of glomerulonephritis is rapidly progressive glomerulonephritis, subacute, or glomerulonephritis with crescents. Main feature of this glomerulonephritis it is formation of the cellular and fibrosis crescents in majority of glomeruli. Duration of disease from 6 months to 1.5 years. Etiological factors are post-infections, like in acute glomerulonephritis, mostly due to beta-hemolytic Streptococcus group A, due to systemic diseases of connective tissue, or most often variant it is idiopathic, so we cannot determine clearly the etiology of disease. Pathogenesis mostly based on immune or antibody-mediated damage of glomerular basal membrane, leading to a violation of its permeability leading to injury of filtration barrier and activation of inflammatory cells with predominant phase of proliferation. Result of this reactive proliferation in the Bowman capsule is formation of so-named crescents. Clinical manifestations of subacute glomerulonephritis are proteinuria, edema, hypertension and hematuria. So mostly this disease comes with nephritic syndrome. Within 6 or 18 months, disease without treatment will lead to progressing uremia and possible lethal outcome. That's why the name of such disease, rapidly progressive glomerulonephritis. Diagnostic criteria of this disease are: from clinical symptoms, this is malignant hypertension, nephrotic or nephritic syndrome, urinary syndrome can be seen. Laboratory studies, it is increasing in serum creatinine more than 200 micromoles per liter during months or 2 times for every 3 months. Immunological criteria: antibodies to glomerular basal membrane, antibodies to leukocyte cytoplasm, which are named ANCA antibodies, and decreasing amount of complement system, which is consumed in the glomeruli. About morphological changes. Macroscopical appearance is very similar to acute glomerulonephritis. Kidneys are increased in size, weight is 300–500 grams, surface is smooth or fine-grained, grained, pale, very often with petechial hemorrhage. Consistency is flabby, is loose. Cortex is usually white, swollen, pale yellow to gray color with a lot of red dots due to petechial hemorrhages. Cortex is usually well demarcated from dark red medulla. Such appearance is named large mottled kidney. If there is no clear border between cortex and medulla, such kidney is named large red kidney. It is also possible variant in rapidly progressing glomerulonephritis. Microscopically, we will see two variants, intracapillary and extracapillary. Intracapillary glomerulonephritis is almost the same like morphological picture in acute glomerulonephritis. But the most often variant is extracapillary with formation of crescents. Due to proliferation of epithelial cells in the Bowman capsule, proliferation of podocytes, macrophages, which accumulates outside the glomerular capillary loops in the lumen of Bowman capsule, the crescents are formed. Glomerular capillaries undergo necrosis, and their lumens can contain fibrin thrombi. Epithelium of the proximal and distal tubules can be characterized by signs of protein dystrophy. Its secondary changes due to initial damage to the glomeruli. Crescents subsequently will be replaced with fibroblasts, which start to produce connective tissue, so in the outcome of rapidly progressive glomerulonephritis, glomerulosclerosis is seen. Glomerulosclerosis is the main reason of chronic renal failure, which can develop in the end of such disease. If this disease progresses very quickly, it can lead to acute renal failure. Other complications of subacute rapidly progressive glomerulonephritis are associated with increased blood pressure, so we can see hemorrhagic syndrome, left ventricular hypertrophy, sclerosis of arterioles in kidneys and brain, liver, and other organs. Chronic glomerulonephritis in clinical types can be divided in 5 groups. First one is latent form. Without complaints, urinary syndrome is often detected by chance. Minor or moderate proteinuria is seen. Microhematuria, that means not very large amount of erythrocytes in the urine. It's enough good form because it has favorable prognosis. Period from the onset of this disease to chronic renal failure usually more than 10 years up to 25 years. Next one is hypertension form. In this case, urinary syndrome is detected simultaneously with hypertension. Proteinuria is usually also mild. Hematuria can be seen, and the prognosis is also favorable usually because period from the onset to the chronic renal failure about 20 to 30 years. Hematuria form. Urinary syndrome with constant macrohematuria and also gross hematuria episodes with discoloration of urine like Coca-Cola. Proteinuria is usually slight and moderate. Prognosis for this form usually also favorable 30 to 40 years before chronic renal failure development. Nephrotic syndrome, nephrotic form, it's enough severe comparing to previous ones. Period from the onset to the chronic renal failure about 8 to 15 years. This type is accompanied by massive proteinuria and hypoproteinemia, especially hypoalbuminemia. Hyperlipidemia, especially hypercholesterolemia, is seen, and severe edematous syndrome. The most unfavorable variant of chronic glomerulonephritis in clinical manifestation, this is mixed form. Mixed form means combination of nephrotic and nephritic syndrome. So we will see all components of nephrotic syndrome, including massive proteinuria, hypoproteinemia, hyperlipidemia, edema, in combination with signs of nephritic syndrome like arterial hypertension, oliguria, hematuria, increased due to all these changes, increasing amount of nitrogen waste products with azotemia, and the usual period of transformation of disease to chronic renal failure from 2 to 10 years. First variant from which we will start, it's chronic glomerulonephritis with minimal changes, or other name lipoid nephrosis. Etiology is unknown. Pathogenesis is based on decreased amount of heparan sulfate, which is proteoglycan, in capillary basement membrane of glomerulus. Result of it, changing in the filtration barrier. Increased amount of plasma protease and especially increased amount of lipids can be found in primary and then secondary urine. Due to reabsorption from the urine, lipid molecules can be detected inside epithelial cells of convoluted tubules. Lipoid nephrosis usually manifested by nephrotic syndrome, without hypertension and without hematuria. Morphological changes. Macroscopically we will see large white kidney, typical appearance of kidney in lipoid nephrosis. The kidneys are enlarged, consistency is flabby, capsule is thin and translucent, can be easily removed. Surface under capsule is smooth, usually has yellowish tint. Cortex and pyramids usually clearly separated. Marked expansion of the cortical layer is seen. Cortex is yellowish-white, pale gray, pyramids are gray to red. Name of such kidney is large white kidney. Microscopically we can find minimal changes because in glomerulus the changes are not severe. The changes in convoluted tubules are seen, but they are secondary to the glomerulus. In glomerulus, only manifestation which can be detected with light microscopy, it's mild thickening of the basal membrane and mesangial expansion. In proximal convoluted tubules, the changes are more pronounced, more severe. It's swelling, increasing in sizes of epithelial cells. Hyaline drop degeneration is possible, but especially a special type of degeneration, it's accumulation of translucent vacuoles which contain fats. Within the tubules, large number of cylinders can be seen. Why minimal changes disease? Because the changes in glomeruli can be detected clearly with electron microscopy. These changes are loss of secondary processes, small processes of podocytes, and accumulation of some immune deposits under the basal membrane. Possible complication of lipoid nephrosis, its replacement of kidney with connective tissue, nephrosclerosis, and development of chronic renal failure. Next morphological type of chronic glomerulonephritis, it's membranous nephropathy. In membranous nephropathy, microscopically we will see thickening of basal membrane of capillary loops due to accumulation of immune deposits, and sometimes the basal membrane, especially in electron microscopic level, resembling tram tracks. In electron microscopy, in basal membrane, we can see typical appearance of spikes and domes on basal membrane. which are located in the place of immune complexes deposition. Mesangial proliferative glomerulonephritis, it's also variant of chronic glomerulonephritis accompanied by severe proliferation of mesangial cells. Due to this hypercellularity, compression of the capillary loops, and narrowing of capillary lumens. From this, all problems will start. Another variant is focal segmental glomerulosclerosis. It's partial replacement of some areas of capillaries with connective tissue. We can see accumulation of fibroblasts, accumulation of collagen fibers, which additionally can be detected with specific staining methods, like here. Focal segmental glomerulosclerosis, it's not total replacement of glomerulus with connective tissue. Only some capillaries, some capillary loops are replaced with connective tissue. Membranoproliferative variant of glomerulonephritis, it's combination of membranous nephropathy and mesangioproliferative glomerulonephritis. Let's remember what are changes in these two variants. First of all, increased glomerular cellularity due to proliferation of mesangial cells, which is indicated by large arrows. Mesangial expansion, indicated by star. And finally, narrowing of capillary lumens, diffuse thickening of glomerular capillary walls, which is indicated by small arrows. All these changes lead to damage to filtration barrier of glomerulus. Fibroblastic glomerulonephritis, like outcome of all above-mentioned types of glomerulonephritis. It's total replacement of glomeruli with connective tissue, so glomerulosclerosis. Additionally, it's sclerosis of periglomerular stroma, which is located around glomerulus, and sclerosis of peritubular stroma located around convoluted tubules. Also, perivascular sclerosis is seen, replacement with connective tissue, the tissues around blood vessels. Possible complications of chronic glomerulonephritis are nephrotic crisis, hypovolemic shock, thrombosis and thromboembolism of peripheral veins and arteries, cerebral hemorrhage due to hypertension, heart failure due to hypertension, increased risk of infections due to depression of immunity, azotemia, uremia, in severe cases DIC syndrome. Amyloidosis of kidneys. Amyloidosis of kidneys, it's one of the variant of stromal vascular protein degeneration, which usually can be seen like secondary changes to some other disease. Amyloidosis of kidneys is the most often variant of amyloidosis. Sometimes it can be primary, idiopathic without clearly known reason. But, as I told, majority of cases are associated with some other diseases. These diseases are infectious diseases like severe infectious tuberculosis and syphilis, chronic diseases associated with purulent inflammation like chronic bronchoectatic disease, chronic lung abscess, also chronic osteomyelitis, which also belong to long-term purulent inflammation. Also, amyloidosis is caused by systemic diseases of connective tissue like rheumatoid arthritis, systemic lupus erythematosus, sometimes rheumatic fever. Hodgkin disease, myeloma, like hemoblastosis, lymphoma, and leukemia, which are also possible reasons for amyloidosis. There are 4 stages in clinical course of amyloidosis. Preclinical stage without clinical manifestations, proteinuria without any symptoms but only changes in urine due to increased amount of proteins in the urine, nephrotic syndrome development with all possible clinical manifestations, and last stage, uremia, accumulation of large amount of nitrogen waste products in the bloodstream. Appearance of kidney, lardaceous kidney. Typically, kidney is enlarged There is unclear border between cortex and medulla. Consistency of kidney become dense. On cut we can see typical waxy appearance of the cut. Tint of kidney is pale brown, dark yellow. Specific method of staining for amyloids is Congo red staining. In light microscopy we can see accumulation of reddish-orange deposits in the wall of blood vessels and in mesangial space of glomeruli. Also, sometimes we can see amyloid deposits between convoluted tubules in the stroma. In polarized light, reddish color of Congo red transforms to greenish. In electron microscopy we can detect amyloid deposits under the basal membrane, in the stroma, in the wall of blood vessels, in mesangial space of glomeruli. Now we are going to tubulopathies. First disease which we will discuss with you is acute renal failure. Morphological equivalent of acute renal failure is acute tubular necrosis, or other name necrotizing nephrosis. Necrosis of epithelial cells of convoluted tubules. Possible causes of acute renal failure can be divided in three groups. Prerenal causes are hypovolemia, in bleeding, in vomiting, in severe diarrhea, in burn disease. Renal hypoperfusion due to aneurysm of the abdominal aorta, renal artery stenosis, hepatorenal syndrome. Hypotension because of shock conditions. And edematous syndrome in case of pathology of other organs like heart failure, liver cirrhosis, and so on. Renal causes are associated with primary damage to kidney. It can be damage to the glomeruli due to glomerulonephritis, can be damage to the tubules, for example, due to pyelonephritis, can be interstitial nephritis, or any vascular lesions of branches of renal artery inside the kidney, for example, in systemic vasculitis. Postrenal causes are associated with internal and external causes for urinary system. Internal causes means some material which stop normal urine outflow. What it can be? It can be stones, it can be blood clots, it can be desquamated papillae in pelvic calyceal system due to papillary necrosis. It can be stricture of ureters, prostatic hypertrophy or cancer of prostate, or benign hyperplasia of prostate, tumors of the urinary bladder, radiation fibrosis, and so on. External causes, these are reasons which compress ureters or urinary bladder from outside. It can be pelvic tumors or retroperitoneal fibrosis in retroperitoneal space. There are four main stages in acute renal failure: initial stage, oliguric and anuric stage, diuresis recovery stage, and recovery stage. Initial stage duration is 1 to 3 hours, and manifestations on acute renal failure are usually masked by the manifestations of primary disease which was the cause of acute renal failure, like manifestations of shock, sepsis, and so on. Oliguric anuric stage usually develops during 1 to 3 days after exposure to pathological factor and is associated with oliguria, decreasing of amount of urine output less than 500 milliliters per day, or anuria, total absence of urine output per day. Duration of second stage usually about 1 to 2 weeks. It is also characterized by edematous syndrome and non-specific signs of intoxication because nitrogen-based products cannot be normally removed from the body, including weakness, lethargy, drowsiness, loss of appetite, nausea, vomiting, and so on. Diuresis recovery stage, it's variant of favorable course of the disease, gradual increase in the volume of urine output, and can be observed during 5 to 10 days. This stage morphologically usually associated with restoration of amount of cells in the convoluted tubules, but these cells are not differentiated. That's why this stage very often is accompanied by polyuria. Means filtration process is normal, but due to damage of convoluted tubules, because convoluted tubules cannot perform secretion and reabsorption, because epithelial cells are young and undifferentiated, the amount of urine output is higher than in normal patient, and polyuria can be seen. Recovery stage. It's complete recovery in case of favorable course of acute renal failure. It happens during 1 year or sometimes even more, and morphologically we will see subsequent differentiation of renal epithelial cells to major variant. Morphologically, macroscopically we will see that kidneys are enlarged, have flabby consistency. Outer surface usually smooth, fibrous capsule is tensed and easily removed. Cortex is dilated, pale, with some red dots due to petechial hemorrhage. Pyramids are congested. On the border between pyramids and cortex we can find corticomedullary shunt, which is passing of the blood directly from the vas afferens to the blood vessels of medullary substance without passing through the glomeruli. Microscopically we will see necrotic nephrosis or acute tubular necrosis. In all cases, glomeruli morphologically are preserved. Epithelial cells of the proximal tubules are damaged, increased in sizes. We can see signs of karyopyknosis, karyorhexis and karyolysis. So we can see just shadows of the cells. Lumen of convoluted tubules is decreased because dead cells are edematous and dead cells begin to be desquamated from the basal membrane, leading to obstruction of the lumen of convoluted tubules. Renal stroma is edematous. In the later period, we will see alternation of necrotic area and area of regeneration. Foci of sclerosis can be seen in later period of disease. Next one, it is pyelonephritis. It's inflammatory disease of renal pelvis, renal tubules and interstitial renal tissue. So as I told, very rare variant, it's true interstitial disease. Usually interstitial disease is associated with tubulopathy, like in pyelonephritis. Pyelonephritis is the most common diseases in nephrologic practice. 60% of all kidney diseases, it's pyelonephritis. But most of them, about 40%, can be reason of chronic renal failure. Pyelonephritis predominantly has infectious etiology. Most often it is caused by intestinal microflora like Escherichia coli, Enterococci, Proteus. Sometimes pyelonephritis is associated with pathological microflora including Streptococci, Staphylococci, Mycoplasma, Leptospira, fungi, and others. Contributing factors are gender. First of all, pyelonephritis, in majority of cases, this is disease of women, up to 2 to 3 times more common in women due to more short and wide urethra. Second predisposing factor is hormonal disbalance between amount of steroids and hormonal contraceptives. These hormones inhibit the immune response. That's why in the patients which undergo glucocorticoid therapy or in women which use hormonal contraceptives, risk of infection is much increased comparing to population. Metabolic disorder. also can be predisposing factor, like diabetes mellitus and gout. Anomalies of kidney and urinary tract which are associated with disturbances of urine outflow and disturbances of renal outflow. It's very important predisposing factor for inflammation, very important predisposing factor for pyelonephritis. Hypothermia, like damaging factor, and also leading to transient decreasing in immunity response, and result of it development of microflora, and result of it formation of pyelonephritis. There are few routes of infection. First of all, it's hematogenous or lymphogenous route, which is descending. Means some infection foci are present in the body, and through bloodstream or through lymphatic circulation, this bacteria can reach kidney. Another route of infection is urinogenic, ascending route. It's more often variant for pyelonephritis, and it is associated with urinary, urethral and urethral pelvical reflux in the urinary system. Infected urine from urinary bladder will pass to ureters, and after that, from ureters, due to reflux, pass to pelvis, causing pyelonephritis. Classification of pyelonephritis according to origin can be primary and secondary, without any other disease or on background of another diseases of kidney, like nephrolithiasis. Nephrolithiasis and pyelonephritis, these are two diseases which comes very often one with another. According the course can be acute and chronic. According morphological changes, acute usually subdivided in serous, purulent and mixed. Majority of cases it's purulent variant, because serous can be detected only within few hours after the onset of disease, and purulent inflammation will be seen after serous. Chronic can be divided in pyelonephritis with minimal changes, interstitial, stromal vascular, and some other variants. Manifestation. Clinical manifestations of pyelonephritis include classic triad: fever, dysuria, and pain. Also, they are shivering, increased body temperature up to 40 centigrades, drenching sweat, pain in the lumbar region. It can be on one side or both sides of the spine. Comparing to glomerulonephritis, pyelonephritis is not always two-sided disease. Sometimes it can be one-sided, and more often it is one-sided disease. Rigidity of the abdominal muscles on the side of the affected kidney, acute pain in costovertebral angle, symptoms of severe intoxication like malaise, thirst, nausea, vomiting, dry mouth, muscle pain, dysuria, including leukocyturia, pyuria, proteinuria, bacteriuria. Morphologically, macroscopically, we will see that one or both kidneys of patient are increased in sizes and have dense consistency. In the cortex and pyramids, we can see difference in sizes, cavities filled with greenish-gray semi-liquid content. So, naturally, these are cavities containing pus, which are abscesses, different in shape and different in sizes. Lumen of cups and pelvis contains cloudy urine or greenish-gray semi-liquid content, pus. In case of hematogenous descending route of infection, abscess is mostly located in upper pole. In case of ascending route, abscesses are mostly located in lower pole of the kidney. Microscopically, we will see that lumens of collecting tubules contains a lot of neutrophils. There is edema, congestion, and severe diffuse or focal leukocytic infiltration. There is a lot of necrosis and hemorrhages. When healing, necrosis and inflammation area become substituted with connective tissue. Possible complications of acute pyelonephritis are associated with purulent complications. First complication is necrosis of renal papillae, papillonecrosis, which is seen in diabetes mellitus patients with pyelonephritis. Due to this, papillae can be rejected to the lumen of pelvis calyceal system, leading sometimes even to the obstruction of ureters. Apostomatous pyelonephritis, it is multiple small abscesses in the kidney. Kidney carbuncle, it's total purulent lysis of kidney substance. So kidney will be seen like sac filled with pus, but pelvic calyceal system and fibrous capsule are preserved. Pyonephrosis, it's filling of the pelvis with pus, and pyonephrosis can be seen in high ureteral obstruction and the result of breakthrough of carbuncle of kidney. In this case, fibrous capsule is preserved, renal substance is replaced with pus because of destruction of renal substance, and this pus is accumulated inside the pelvic calyceal system. Sepsis, like the most severe complication, including generalization of infectious process and migration of bacteria with blood. Paranephritis, inflammation of perinephric adipose capsule. Perinephritis, inflammation of the fibrous capsule of kidney. Kidney abscess, like single large abscess in the kidney substance. Here we can see pyonephrosis, when the renal substance is replaced with pus, pus is accumulated inside the pelvic calyceal system and passes to the ureter. Chronic pyelonephritis, it's possible outcome of acute one. The possible reasons are urodynamic disorders, focal infection, and improper treatment of acute pyelonephritis. Many years it can pass without any symptoms, be latent. Only urine test will show us some changes in the urine. Clinically is manifested by the dull persistent pain in the lumbar region on the side of the affected kidney. Morphological signs of chronic pyelonephritis and morphological signs in chronic glomerulonephritis, which can be seen macroscopically. So one more time, both pyelonephritis and glomerulonephritis macroscopically have almost the same appearance, which is named secondary shrunken kidney. The kidney is decreased in sizes. The consistency of it is very, very dense due to growth of connective tissue and due to replacement of some area of renal tissue with connective tissue. External surface of kidney is macronodular. Capsule is sealed and removed difficulty. On the surface we can see whitish grayish area of the scar tissue formation. Cortex and pyramids may contain cavities in case of pyelonephritis with greenish-gray semi-liquid substances. So in chronic pyelonephritis we can see sometimes presence of abscesses which begin to develop in periods of exacerbation. In period of remission, these abscesses will be replaced with connective tissue. Of course, in glomerulonephritis in chronic variant, abscesses cannot be seen, they are absent. Deformation of pyelocalyceal system can be seen in both chronic glomerular and chronic pyelonephritis. Microscopically, lumen of the collecting tubules contain a lot of neutrophils in period of exacerbation. In period of remission, neutrophils are absent and predominant leukocytic type in the renal stroma. These are lymphocytes and admixture of macrophages. In tubular epithelium we can see dystrophic and atrophic changes. Tubules usually become dilated. They are lined with flattened epithelium, and distal tubules and collecting ducts can be filled with so-named colloid-like substance. Colloid-like substance, it's accumulation of different types of protein inside the lumen of kidney. This appearance will give kidney appearance of thyroid gland. In the right side you can see usual normal histological structure of thyroid gland. In the left side this is kidney, which resembles thyroid gland. And this pinkish message, this is colloid-like substance. The composition of this colloid-like substance, this is dead and desquamated epithelium cells of convoluted tubules. This is protein from the blood due to damaged filtration barrier. This is dead neutrophils and other inflammatory cells which also accumulates inside the lumen of convoluted tubules. Sclerosis is also seen in chronic pyelonephritis, affecting first of all peritubular stroma around convoluted tubules, but after that it can spread to glomeruli with development of glomerulosclerosis. But glomerulosclerosis in chronic pyelonephritis, it is secondary change to the damage of convoluted tubules. Possible complications of chronic pyelonephritis are chronic renal abscess, renal hypertension, which can be very malignant, uremia, chronic renal failure in 15% of patients. And about chronic renal failure. Chronic renal failure is characterized by increased level of nitrogenous waste substances in the blood, mainly due to severe decrease in the number of functioning nephrons. Result of it's accumulation of these products, waste products in the bloodstream, which is named uremia. Uremia syndrome which is characterized by autointoxication with the products of metabolism, uremic toxins and exogenous compounds normally excreted by kidneys. Etiopathogenesis of chronic renal failure includes disorders with primary lesion of glomeruli, like any variant of glomerulonephritis, especially chronic and subacute. Disorders with a primary lesion to tubules and interstitial spaces, like chronic pyelonephritis, interstitial nephritis, some nephropathies like Balkan nephropathy. Obstructive nephropathy including urolithiasis, hydronephrosis, tumors of the genitourinary system. Primary vascular lesions including malignant hypertension, renal artery stenosis, and any other hypertension. Diffuse connective tissue disease, especially systemic lupus erythematosus, systemic scleroderma, and systemic vasculitis. Metabolic disorders like diabetes, gout, amyloidosis, and some congenital renal diseases like polycystic kidney, renal hypoplasia, Fanconi and Alport syndromes. Manifestations of chronic renal failure can be divided on the affected organ. Due to uremia, nitrogen waste products begin to be excreted by all mucous membranes and skin because they cannot be excreted with other way, with normal usual way through the kidney. So they will be excreted with mucous membranes in GIT, mucous membrane in bronchial tree, and they can be excreted with the skin. So what changes we will see in skin? Skin become pale yellow due to accumulation of pigment of urine which is named urochrome. Due to accumulation of these waste products in the skin, it become dry, face become puffy, skin become powdered because crystals of urea and uric acid are accumulated on the surface. Because of it, rash, scratching, especially in the legs, due to pruritus, and result of it subcutaneous hemorrhages in the manner of petechia. In cardiovascular system, elevated blood pressure due to renal hypertension, increased dimensions of the heart, myocardial dystrophy, sometimes inflammatory complications like uremic myocarditis and fibrinous pericarditis due to damage with nitrogen waste products. On ESG, we can find arrhythmias, sometimes bradycardia, less often tachycardia. Heart failure in association with chronic renal failure, and it is significantly worsens the prognosis. In respiratory systems, due to excretion of nitrogen waste products, we will see such signs as cough, uremic laryngitis, tracheitis, and sometimes uremic bronchopneumonia. Fibrinous pleurisy, because nitrogen waste products also exit through the pleura, like through the other serous membranes. Increased predisposition to lung infections is also seen. In digestive system, due to inflammatory changes in pharynx, pharyngitis, oral cavity stomatitis, esophagus esophagitis, stomach gastritis, and damage to intestine, enteritis and colitis. Symptoms are nausea, vomiting, thirst, anorexia, weight loss. Sometimes uremic peritonitis can develop. Sometimes fatty degeneration of the liver. In the nervous system, manifestations are malaise, headache, meningismus means presence of clinical manifestations of meningitis, insomnia and drowsiness, emotional lability, apathy, impaired hearing and taste, deterioration of memory and mind, speech disorders, tremors, convulsions, stupor and coma. In peripheral nerves, symmetrical sensomotor polyneuropathy, burning pain in the feet and legs, muscle weakness up to paresis and paralysis, and toxic effects of uremic toxins on the brain, resulting to headaches and individual muscles twitching. In severe case, apathy, which is named quiet uremia, or eclampsia, due to increased intracranial pressure, which is named noisy uremia. In reproductive system, amenorrhea in females, impotence in males, gynecomastia in males. Musculoskeletal system, osteoporosis of bones due to calcium loss, osteomalacia, and secondary hyperthyroidism. Additionally, can be seen anemia due to absence of erythropoietin, which is normally produced in kidneys, effect of uremic toxins on the bone marrow with inhibition of erythropoiesis, also hemolysis of erythrocytes due to action of uremic toxins, hemorrhagic syndrome, including hematuria. Arterial hypertension and result of it due to hyperproduction of renin, due to decreased formation of prostaglandins, decreased sodium extraction, and as a result, increased extracellular fluid volume. And renal osteodystrophy, which is caused due to reduced formation of active forms of vitamin D, decreased calcium uptake in the intestine because of inflammation in small intestine, enteritis, glomerular acidosis, reduced excretion of phosphate leading to hyperphosphatemia, hypocalcemia, stimulation of parathyroid glands, and bone resorption. Cause of death in chronic renal failure, it's progressive failure of organs and systems because uremic toxins damage all organs and systems of the organism, leading to polyorganic insufficiency in the body. Thank you for your attention.